Well, I began my career in healthcare as a public health person. Earned an undergraduate degree from the University of Tennessee in public health education. Then I went back to school and earned an associate degree in nursing at Lincoln Memorial University, and then went back again and earned a master's at the University of Tennessee as a pediatric nurse practitioner. Um, and then eventually went back to school when I moved to Missouri and uh, earned a PhD in nursing. And my focus was on children with asthma, and my work was around listening to their experience. So I use phenomenology, which really is just a way to understand and share the experiences children have. So no constructs, not trying to make anything of it, just wanting to understand what happened to them at school, at home, in the community, and at the doctor's office or the clinic. And for me, it was a real eye opener, and I really in that study I focused on children with disabling asthma, and sadly, there are many children at that point, about 1 million children in the U.S., who were experiencing extreme impairment where they just couldn't do things other kids could. So I looked at what was happening to them. And the wake-up call for me was we needed to do a better job everywhere, in the clinic, at school, in the community. And so that's still pretty much my life's work. And so I'm very passionate about asthma, and I'm also very passionate about the role of school nurses. I had the privilege to work with our state school nurse consultant, Marge Cole, and travel all across the state, working with school nurses, looking at their needs, trying to help get the equipment they needed, the educational curricula for their students, and just to help keep everybody up to date. And that is a challenge. So I'm currently employed by the University of Missouri School of Medicine, and I'm a teaching professor here. I do some basic research around what causes the changes in our airways. We're looking at something called exosomes, and they're little droplets that cells emit as a way to communicate with other cells. So our nose does talk to our lungs, and we'd like to understand that better, and maybe eventually have some simple tests like a spit test, a saliva test, that could tell us reliably what might be happening in the lungs as sort of an initial way to address asthma. I have spent the last 15 years working with the Centers for Disease Control through the Missouri Asthma Prevention and Control Program, and we saw early on the need to pull communities together with sort of a collective impact approach, meaning that it's not just the doctor or just the school nurse, but it's the doctor, the school nurse, the nurse practitioner, the social worker, the community health worker, the health department, the home assessor. We need all those folks on the same page. So we have a federal trademark called Asthma Ready Communities. And with that, we've been able to work with hundreds of communities across the state of Missouri, and still learning, still have a ways to go. But it's exciting, and we are seeing big differences. In particular, we're seeing clinicians reach out to school nurses and say, can you help me? I've got this child that has severe asthma. We've changed their regimen. I don't know if it's going to work. I need your help. And we love that there's a partnership between school nurses and clinicians and respect between the two. So next slide. We're going to kind of start our time together by looking at the updates that were published last December. And I'll give you a little history about where asthma guidelines come from in the US, but we had gone a number of years with no update to our national guidelines. So in December, the focused updates were released, And it's not a new version of the expert guidelines. That EPR3 stands for Expert Panel Report, third version, and that stood, but with some updates. And there are actually 6 selected topics for the updates. And the way this was done was unique. Historically, a committee would come together at the national level, and they worked for months, sometimes years, to come up with the expert panel report recommendations for asthma. This time, they actually bid out the literature review to academic centers around the country around 6 topics: intermittent inhaled corticosteroids, a new asthma medicine for pediatrics at least, long-acting muscarinic antagonists. There was a lit review around indoor allergen reduction, what works, what doesn't, a review of immunotherapy, a detailed deep dive into whether pheno testing fractional exhaled nitric oxide has a role in asthma management. And finally, a procedure that's reserved for adults with severe intractable asthma called bronchial thermoplasty, which we won't spend much time talking about that. But if you look at what the updates included, it was really well put together. And I say that because there is a level of information to meet everybody's needs, including parents and children. One of my favorite things about the update, and I'll share some of these, are the patient fact sheets. And I think at least 4 of them have a role in your office, your health office at school, because they answer questions that many parents and students have. The entire update was huge, 322 pages. I haven't read it. What I have read in detail and what I have referenced in that 322-page document are selected topics that are important to pediatrics. So there is a synopsis. It's 16 pages long, and that's what we're encouraging clinicians to read, because no one has time to read 322 pages today. And then there's a critical short set of tables, 6 pages long, that really changes how we approach the stepwise treatment of asthma across all age groups. Next slide. So this expert panel working group is convened by the National Heart, Lung, and Blood Institute at intervals that are deemed important because of innovations or breakthroughs in the treatment of asthma. And this is part of a long-standing effort called the National Asthma Education and Prevention Program. They first published their results in 1991 with EPR1, and then in 1997, EPR2, and in 2007, EPR3. So you can see that we went from 2007 to 2020 with no major revision, and that had to do largely with the facts were pretty stable. The evidence around what works best for asthma did not change dramatically over a decade or more. So the guidelines updates were welcomed. They were evidence-based. They use a system called GRADE, and GRADE just stands for Grading of Recommendations, Assessment, Development, and Evaluation. So it's a rigorous way to say, do we really have enough evidence to make a recommendation? And if we're going to make a recommendation, is it a strong one or is it conditional? And I think this just reflects the fact that our knowledge base is always changing. And historically, we've used expert opinion when we didn't have strong studies, well-designed studies. And today we're trying to be more careful when we make recommendations to know the level of evidence behind it. And it's okay for things to change. We're never going to get it right the first time around in things that are new medications, new techniques or treatment approaches. Next slide. So maybe this is the most important slide. If you click on that URL, that will take you to the resources for the updates. It's called a digital toolkit. And this is what I send out many times a month to people who are saying, how do I access the updates and these great fact sheets? Next slide. So the fact sheets, there are 7 of them, and several are really particularly helpful for school nurses, I think. Next slide. And I've kind of lined up the 4 that I would think you would want to have in your office, maybe on the wall, where you could readily access them or parents could access them, or elsewhere in the school where that would be helpful. The first one is asthma management guidelines and your care. And I tell clinicians, start by reading that. This is a great overview of the 2020 updates, and it's in plain language, and it makes a lot of sense. And then the second document I think is important for you, as a school nurse, and this is one I copy and I hand out in the clinic where I see kids with asthma, and I highlight the section that relates to that age group and the treatment approach that I'm going to be using. But the title sort of says it all: the changing role of inhaled corticosteroids. Things have changed significantly, and we're going to try to hit the high points today. And then there's an area I think that's always been controversial, and that's does immunotherapy help? And if so, who really needs it? And what's the role of just trigger reduction? Sometimes people jump to immunotherapy, but they don't do the environmental changes in the home or in the school that would likely resolve the problems most of the time. So I think reducing allergens in your home, and this applies to the school as well, is super important. And I think as I've done this work over the last 25 years, I've learned that the word remission is super powerful, and it's not applied to asthma as often as it should be. So for me, when you say remission, that gives you hope that whatever your disease, perhaps we think of cancer as the most common one, that in remission means it's not active, it's not causing ill health or impairment right now. So I can't emphasize enough the balance between turning off, getting rid of, reducing the things that have caused your asthma to be expressed. Yes, you have the genetics for having asthma, if that's a problem that you've experienced, but it's the environmental exposures that drive that. Early on, it's mostly viral infections that are largely unavoidable. Everyone's going to have RSV by age 4. We're going to keep getting it. And most of you probably noticed this summer, there was an unusual load of viral infections, RSV, parainfluenza, enterorhino. These are typically infections that we see in the winter months. We begin to see them when kids are back in school and they're cohorting, they're side by side. But it's an unusual event to see it at peak levels in the summer, and that is exactly what happened to us. But beyond viruses, we certainly can do a lot about the other triggers, cockroach, dust mite, mold, and we can anticipate seasonal things. When will the tree pollen start and when will it end? When will the mold begin? When will it end? And we really are putting a greater emphasis on the balance between using medications when you need them, but doing everything in your power to reduce the expression of asthma. And what we see is many, many children do go into remission, meaning that during childhood or the teen years, they reach a point where they no longer need a daily inhaled corticosteroid, or they may not need their nasal steroids, or infrequently need antihistamines. And by understanding that relationship between the environmental trigger, what's turning on inflammation, and that particular child's asthma pattern is super helpful. Next slide. So again, start with this one and just read it. It's an easy read, and it's super well written, and it's a nice overview of the guidelines. Next slide. What I want to do now is highlight for you the items that we would think of as pretty big changes compared to how we managed asthma in the past. And each of these are discussed in that fact sheet in a little more detail. So one of the raging debates in asthma care for as long as I've been involved has been, do intermittent inhaled corticosteroids work? And historically, there was no real good evidence that I could give you Flovent for 10 days and that it would make any difference. Part of the rationale behind believing that is that we know persistent asthma is accompanied by changes in the airways. And I like to say it's changes in both the architecture of the airways and the habitat. The other way to say that is the cells change, the landscape inside, the landscape inside our lungs changes with chronic inflammation. And the big thing that we all can relate to is that the lining of the airway begins to lose its cilia. And when you lose cilia, you're very prone to having prolonged respiratory infections, particularly viral, and perhaps at greater risk for secondary bacterial infections that we would label as pneumonia. Beyond just losing cilia, though, cells enter the airways that shouldn't be there. And those cells are coming out of the bloodstream, and they're mostly eosinophils, but a host of other inflammatory cells as well. So the idea that I could give you Flovent for just 10 days and change all of that was hard to swallow for us historically. But there are differing levels of inflammation. And at one point, you can say, whatever the provocation, whether it's pollen or a virus, you may be able, with a short course of inhaled steroids, to reverse that, or to prevent the cascade, the worsening pattern of inflammation. So here's what there's enough evidence to back up. Here's where we have enough evidence to back up a change in practice. In children ages 0 to 4 who have recurrent wheezing, but in between their viral infections, they're well and they're not impaired, then a short 7 to 10 day course of inhaled steroids, along with a short-acting beta agonist, albuterol, is recommended at the start of a respiratory tract infection. So what does this mean? It means that some of the kids that we were putting on inhaled corticosteroids for months and years in the first 4 years of life may do just fine if we only start the albuterol and the inhaled steroid at the time of the respiratory infection. So when they first start showing signs of a cold. This is not going to work for the child with moderate to severe persistent asthma who's been in the ICU and who, even between their colds, has persistent cough or shortness of breath. But there are children where this makes sense, and it's safer than 5 days of prednisolone or a shot of dexamethasone. So certainly it's worth trying, and there is enough evidence that that's a new recommendation. However, in children 4 years and older, with mild to moderate persistent asthma, studies have not really shown conclusively that simply stepping up their dose of inhaled steroid would be effective. So that currently is not a recommendation. Next slide. For people ages 4 and older with moderate to severe persistent asthma, and this is a big change. The preferred treatment is a single inhaler that contains both an inhaled corticosteroid and the specific long-acting bronchodilator, or Moderol. And we're going to talk more about this. And this, you may have heard people talking about the SMART plan or SMART therapy. And that's the single maintenance and reliever therapy, where instead of having a quick reliever and having an inhaled corticosteroid, two different inhalers, you have them as one, and you're able to use that one inhaler both for symptom control and for your regular twice a day, every day control medication. People ages 12 and older with mild persistent asthma actually may benefit from inhaled corticosteroids being given for a short duration with a short-acting beta agonist. So in contrast, 2 years ago, if we said you had mild persistent asthma, we were going to recommend you take inhaled steroids twice a day, every day. And in truth, this is their preteen and teenage group here. They often didn't. They didn't take those controller meds because they didn't feel like they needed it, and they didn't feel like it was making any difference. Of course, you know, as we've just talked about, it takes 3 months to heal the airways when you have persistent asthma. But now there is significant evidence that says those kids will do just as well if they mild persistent, if they use their inhaled corticosteroid during the time when they're having problems, and then they could stop it afterwards. Now, a real important point is there's a whole lot of people who think they're in this category, but when you do their lung tests, when you measure airflow, either with a handheld meter, getting FEV1, or with a machine getting full spirometry, they have persistent airflow obstruction, and they're not good candidates for this intermittent approach. But for the preteen and teenager who actually has normal spirometry, but a history of a rough week in April or October or whenever, then this is a good alternative. I do want to mention that several companies are developing a combination inhaler that will basically be like Flovent with albuterol. So a combination, not a long-acting, but a short-acting budesonide with albuterol. So we're going to see that new combination within the next couple of years come to market. And in part, it's in response to these guidelines. Next slide. Are we doing okay out there? Angie, we okay?
Doing great.
All right. I feel bad talking so much, and I miss seeing your faces, but I'll try to get through this content. We'll do this first slide set, and then we'll stop and get your questions. And then I have a second slide set that we can use parts of if we need it, that really is the story of how Missouri is responding to COVID-19 to make sure asthma services at school are as good as they can be and as safe as they can be. Next slide. So there is a new class of medication, and this one for me is very interesting. We've had our biggest debate in the state of Missouri around school asthma services was the role of ipratropium. And I want to just tell you that ipratropium or Atrovent has been around for many, many years. And it has been studied extensively, and it's safe and effective. But I want to kind of back up and talk about why it's important so that we can understand this new class of asthma inhalers called LAMAs, or long-acting muscarinic antagonists. When you think about what can open up our airways when they've suddenly closed down, and we call that hyper-responsiveness, when my airways are sensitive and I breathe grass pollen, and within minutes I get bronchospasm, and I get that because mast cells, special kind of inflammatory cells in our airways, have stored chemicals, and they're going to release those when grass pollen combines with an antibody, and it goes to the surface of the mast cell and opens the door so that whatever's in there can come out. And so once your airways squeeze tight, We use albuterol, which is like adrenaline, and it's working on the sympathetic nervous system side of things to break that bronchospasm and open up the airways. But on the other side of the central nervous system, the parasympathetic nervous system, we have nerves that actively close down the airways, and that's mediated by the vagal nerve. And there are drugs that block that, and it's like taking your foot off of the brake. So the parasympathetic nervous system pushes to clamp down or stop and limit airflow. And ipratropium, which many of us know as Atrovent or Duoneb, it has combined both albuterol and ipratropium to get things open quickly. And here's the way I like to think about it. If I have a sudden surge of nausea, that's a cholinergic response. The parasympathetic nervous system is simultaneously closing down my airways in anticipation that I might have vomiting, and with that is a surge of secretions into the airways. So when you use a long-acting muscarinic antagonist, you're preventing the parasympathetic nervous system from squeezing and producing a flow of secretions that may also block the airways. And we'll talk more about what's the role of this new medication. But in Missouri, we actually have a protocol for life-threatening asthma where Duoneb is there, albuterol premixed with ipratropium, and it's available, and the nurse can use that for a severe asthma exacerbation. And always an ambulance is going to be called in that case. But it's highly effective. And in Missouri, we have counties with no ambulance service at all now. So essentially, that school nurse is going to have to administer that first Duoneb dose and maybe repeat it in 20 minutes. And this can be life-saving for students who do not have access to a children's hospital or even a critical access hospital. So for people 12 years old and older, if a long-acting beta agonist, and there's two of them on the US market for children that are widely used. One is in Advair, which is salmeterol. The other is formoterol, and that's in Dulera and Symbicort. If for some reason a child cannot use that class of medicines, and it would be related to side effects, which can be like albuterol side effects, tremor, irregular heart rate, a sense of fear or nervousness that comes with the use of that medication, then a LAMA could be used instead. If, on the other hand, 12 and older, they're already on an inhaled steroid plus a LABA, and the asthma is not well controlled, then you could add this new class of medicine to that as well, LAMA. And you may have noticed there's a lot of advertising on TV for these products. The latest one is an inhaler called Breztri, Breztri, and it is exactly that. It's basically Symbicort plus this long-acting muscarinic antagonist. Next slide. All right, we'll switch gears here a little bit. That was a lot of pharmacology. It gets a little heavy after a while. But immunotherapy. So many people who have parents who have children with asthma kind of rush to get immunotherapy, rush to an allergist. And I say that because there is good evidence that immunotherapy is appropriate for selected kids, but you might conclude that many more are on immunotherapy than might be justified. And a lot of this is sublingual immunotherapy. So the guidelines, after extensive review, here's where we stand today. Allergy shots, or what are called subcutaneous immunotherapy, are recommended for people who have allergic asthma and whose symptoms worsen after exposure to certain allergens. And that "and" is really important. It's not just a blood test or a skin test that says I'm sensitive. but it would be the child who, when they are exposed, they have significant worsening of their asthma. And that's not everyone, but I can think of specific kids who, if they go into a friend's house and it's a house with a cat, that child's going to get desperately ill and will end up in the emergency room. And that's not like everyone who's, quote, allergic to cats. There are people who have elevated blood levels of antibodies for cat or skin prick reaction, but they certainly don't have serious asthma symptoms. They may have sniffles, sneezing, but not sudden asthma problems. The corollary to this is sublingual immunotherapy, which is where you put drops or tablets that has an allergen under your tongue. There is no evidence to date that that's effective for the treatment of allergic asthma. So if you're one of those people with asthma, when you get in contact with your allergen and you are going to have serious asthma symptoms, then subcutaneous immunotherapy for that specific allergen is the way to go. Next slide. So, you know, we're always hearing about and seeing new technology in healthcare, and this came out about 15 years ago. And we took a hard look at it in our clinical practice. We're a specialty practice. We have never used exhaled nitric oxide testing as a way to estimate how much asthma you have. I have pulmonologist friends, and they do use it, but they use it to a limited degree and more as a point of clarification. So this has been debated. Is it helpful? Is it not helpful? Is it one more test, one more charge to the patient? Or is it really giving me information that I don't otherwise have? And so this is what the expert guidelines are telling us, that testing of individuals 5 and older is recommended when either the diagnosis or the approach to therapy is uncertain. What that means is if we can't use spirometry and other assessment approaches and effectively manage the asthma, then this may help us identify which kids are actually reasonably well controlled and which kids still have inflammation. So fractional exhaled nitric oxide is an indicator of ongoing airway inflammation. And of course, we're using inhaled steroids to try to suppress that inflammation. So low levels would be encouraging and higher levels would suggest that our therapy is not quite where it needs to be. Pheno testing is not recommended by itself to assess asthma or to predict the course of asthma. And in children ages 4 and younger who have recurrent episodes of wheezing, it has not been helpful to predict the future development or in the management of asthma. Next slide. So this, I love this. This came out from the National Asthma Control Program, Heart, Lung, and Blood Institute. I guess it's been 15 years. And this is really about what can you do as a school nurse to have an impact on asthma and to help your students stay in the classroom, avoid impairment from breathing problems. And these 6 areas, I think, are terribly important. The first is inhaled corticosteroids. We all know that word, steroid, evokes fear, and we need to be part of the education process in the school setting, in the clinic setting, at the pharmacy, community agencies. Everyone needs to help clarify that what an inhaled corticosteroid is it's much like natural occurring hormones. And we're dosing it at micrograms, which is millionths of a gram, tiny amounts. And they're being applied to the lining of the airway if we breathe them in correctly. And they're highly effective. And they are the least growth suppressing thing that we can do. And that compares to, I could give you systemic steroids and knock out your inflammation. That clearly is 1,000 times the dose of steroids and very likely to cause side effects if I keep giving you oral steroids like prednisone, prednisolone, methylprednisolone, and so forth. The most stunting thing you can do is ignore a child's asthma. So way back in the 50s and 60s, studies were showing that in fact, if you had moderate to severe asthma that was untreated, your growth would suffer as much as an inch per year during the years of rapid growth in the school age years. So anyway, we can help families be comfortable with inhaled corticosteroids, and again, help them understand that suppressing inflammation and managing the triggers in the environment can help that child experience remission, which would be a period of many months or years where no medications are needed. Without that 90-day course, 3 to 6 months of inhaled steroids, the inflammation is likely to persist for years and even perhaps for decades. So it's very important. Asthma severity is a way of estimating how much asthma someone has. And I love, one of the kids I interviewed in my work said, Johnny, he's got just a little bit of asthma. You don't see him with trouble unless he's trying to run really hard for a long time. But Bobby, he's got a lot of asthma. He has to stop halfway up the stairs because he's so short of breath. So I love that because it's an innocent but accurate way of describing severity. You will see kids that are very limited, and whereas you may not assign moderate persistent or severe persistent asthma, helping that clinician know that they're not functioning at a normal level is really, really helpful. That's contrasted by the concept of control. Control implies we're doing something to try to put the asthma in remission, to suppress inflammation. And clinicians make decisions and put kids on meds, but you're the one really more than clinicians and doctors, nurse practitioners. As a school nurse, you're seeing them over the long haul, and you know whether they're still experiencing impairment or whether they're well controlled. And being able to report that back is really helpful, not only to get additional therapy when it's needed, but we want to step down for kids who are well controlled. So knowing that this child's running, playing, singing, dancing, doing all of the things that are aerobic in nature and not limited by their asthma, by breathing problems, is encouraging for us to be able to step down the dose. And then follow up. You know, so many families fall out of care, and we are responsible for some of that as clinicians because we're not doing all the things that are valuable to families when they come to clinic. And that's part of my crusade, is making sure there's a value proposition. So you came to see me today, and what did you get out of that visit? I want you to have a well-written asthma action plan that you can share with the school nurse, and you can have in both households for kids who are living between households. I would like you to go home with a new chamber, the latest and greatest, which we're going to talk a little bit about. I would like you to go home with a can of 3% saltwater spray that you can use to clear your nose during allergy season or when you have a cold. I would like you to go home with a dust mite cover for your pillow to get you started if I've tested you and shown that you're allergic to dust mites. So all of these things add value, but we also need you as a school nurse to say, you know, if it's been a year since you've seen your asthma provider, it's time to get a breathing test and to rethink whether your treatments are working for you. And then finally, allergen and irritant exposure control. I know as a school nurse, you struggle with these creative teachers that bring into the classroom things that are clearly going to trigger asthma and allergy in kids. And that dialogue is important. And many of our buildings are aging, and we have ventilation problems, we have mold problems. So reaching out and getting help to do that environmental assessment is really important, and often the fix for these problems is inexpensive. So these are the 6 global things that are really important that you guys can do. Next slide. One of our favorite sort of hands-on things is to have this chart on the wall, and this is available. You can't read it, but the URL is down there in that white box. It's the Allergy and Asthma Network. These are about $4 or $5 if you bought one directly from Allergy and Asthma Network, Mothers of Asthmatics. But these are all of the current respiratory inhalers, and what I like is they're by group. Like all of these just have an inhaled steroid. This group has an inhaled steroid plus a LABA. This group is that long-acting muscarinic agent that we talked about earlier. And these are just albuterol in various forms. So having that on the wall and having a student be able to say, yeah, I have this one, but this is the one I took this morning. You know, it's the red one. I'm taking the albuterol because it makes me breathe better. I'm not taking the orange one because I don't think it helps me. It doesn't make me feel better. So that dialogue is super important. And having this photo chart lets you get closer to what students have at home and what they're actually doing for their asthma. Next slide. So to some degree, I have to say, you're going to probably have a role as an inhaler detective because there's all of these new inhalers, and some of them are not on that chart yet. And you're going to have to ask some questions about what's in this. Is it 1 medicine? Is it 2 medicines? Is it 3? And I don't think this is going to get better. As I mentioned, we're going to soon see ICS-SABA, which is basically an inhaled steroid with albuterol. So I think we're just going to have to break it down and learn one by one. And if our student shows up with Allergy, which is a powder inhaler that has the ICS-LABA-LAMA combination, hopefully after today you're going to know why they're there with it. But it will pose challenges for teaching technique because it is a dry powder. So I don't think we're going to get around this. On the left, I did put for you the 2 inhalers in this ICS-LABA group that are eligible for the SMART plan. And here's why I put them there. You may see a student pull out one of these at school for quick relief because technically that is approved now. And a year ago, we would have said, why are you doing that? That's not how you use these inhalers. Next slide. We'll talk a little bit more about the SMART plan in a minute. We'll come back to that. So when you're thinking about what's the best reference to have to help me navigate all of these different inhalers and different treatment approaches, the best guide is this one. It's 11 pages long. You can read it cover to cover in 45 minutes. At least you would know what's in there. And it's very digestible. Next slide. What changed, the 2020 update, is when you get to page 7 in this quick reference guide, it's therapy steps. And those therapy steps changed. So that's the update. You're going to have to take those 6 tables that I mentioned earlier, and you're going to have to look at the 5 to 11 and say, why would they be sending Symbicort to school? Is it normal for a child to take 2 puffs of Symbicort twice during the school day? And the answer is it could be. If it's a bad week and they've been instructed to step up, they can take up to 8 puffs of a medicine like low-dose Symbicort or low-dose Dulera in a single day if they're less than 12. And if they're 12 and older, it's now approved for up to 12 puffs. So I don't expect in 10 minutes for everybody to be completely comfortable with this, I just want you to know that we're going to have to look at these changes in the asthma guidelines to understand whether a student's use is appropriate or not. Next slide. So in the table from the 2020 update for 5 to 11, what I've circled there in step 3 and step 4 is the PRN use of an ICS formoterol inhaler. So that would be Symbicort or Dulera. And so it is part of the recommended treatment strategy. Next slide. So to summarize this, SMART stands for single, maintenance, and reliever therapy. And it's basically one inhaler is being used to manage my symptoms and for my control doses. And the strategy is that when I take Symbicort or Dulera, it will act like albuterol to stop my cough, wheeze, or shortness of breath. But I am simultaneously increasing the anti-inflammatory therapy. I'm stepping it up. So the study showed that when this approach was used over the course of months and years, children used less inhaled steroid, had fewer attacks, and they grew a little better by about a centimeter. So it is an evidence-based approach, but we're going to have to get used to it. And you're probably thinking, how can they afford to have a Symbicort or a Dulera in their pocket at school? And will they use a chamber? Because otherwise they're eating the medicine rather than breathing it into their lungs. And the answer is many kids will not be able to afford to have Symbicort at school. But for their use at home, they would be able to take 2 puffs in the morning. And if they have a rough day at school, they would come in after school and take 2 more puffs, and they would take 2 more puffs at bedtime. But the key is this is for a 7 to 10 day period. This is not year round. And it does work. And again, you see those max doses. That was my question. When I heard about this therapy, I went, oh my gosh, how many puffs of Dulera or Symbicort are they going to take? Now, the strategy for making this work is we're generally giving kids 1 puff in the morning and 1 puff at night of a stronger preparation, say the medium dose version of Symbicort or Dulera. And therefore, they're only using 2 puffs a day, and an inhaler will last them 2 months if all is well. If they have a rough week and they use up to 8 puffs or 12 puffs a day for a week, they will still have enough medication for the dispensing period, and the financial burden is going to be minimal. So that's how many clinicians are incorporating this SMART strategy. But again, I think you may see this at school. It's important for you to know Advair, the purple inhaler, not approved for this approach because it is not formoterol. It's the other LABA, long-acting beta agonist. It's salmeterol, and there's no studies to support that. Next slide. So 2 additional updates, and I have to tell you that for years, we recognized that montelukast or Singulair was having serious side effects in many kids. After the drug came to market, the brand Singulair, they were required to first update their package product insert to say that in adults, this medication could cause suicidal ideation. And then a year or 2 later, they had to update that product insert again and talk about children and night terrors, aggression, mood swings, inattention, and so forth. So finally, in March of this year, actually, I don't know, it's 20, it should be 21, March of 21, a black box warning was issued, which is the highest level of warning prior to removing a drug from the market. And so does montelukast cause these things in everyone? No, definitely not. But in many people, and we don't have research to tell us exactly what percentage. My guess would be it's in the range of 20 to 30% will have these serious side effects. So be alert for a child or a teenager who has any of these underlying problems and who is also taking montelukast. And then the next item here is that we now do have a spacer widely available that has an indicator, and we're going to look at this so that you can see when the breath starts and when the breath ends. So you can estimate the number of seconds that the student maintained airflow, and that's really important because how far into the lungs the medicine goes and how much of the medicine is going to hit the target cells is dependent on whether they sustain airflow and truly fill the lungs up at the right speed. Next slide. So I do suggest that you go out and look at the FDA black box warning. The statement says that it is associated with serious mental health side effects, and that montelukast should not be used for the treatment of simple allergic rhinitis. It's no more effective than loratadine or Claritin. That was proven a number of years ago in a side-by-side clinical trial. Next slide. So let's focus just for a minute, and we're almost to a stopping point where we can take questions and hear your thoughts and comments. But I saw this years ago. It was published in the journal Chest, and it was a study to just see how people who had asthma and who had an inhaler, how were they trying to breathe their medication into their lungs? So it used a device to measure the flow of air. And whereas the recommendation was that you would inhale slowly at a speed of about 30 liters per minute, which means it takes 2 seconds to get a liter of air into your lungs. The truth was that over 92% were inhaling far too rapidly. So what that really means is we were doing a poor job of helping people generate the kind of airflow that would lift these aerosol droplets that come out of a metered dose inhaler and carry them around the curves of our airway so that they would be deposited deep in the lungs where asthma lives and where the effects would be most beneficial. Next slide. So this is one of my favorite pictures, and we have this laminated, and I go in and out of clinical rooms a dozen times a week with this picture. And it basically, if you look carefully on the right, this is a real person discharging a metered dose inhaler into their mouth. It's radio labeled flunisolide. That's an inhaled steroid in the brand Aerobid. And what you see is a huge dose to the mouth, and then you see it in the back of the throat, and then you see it go down the esophagus. And then at the bottom of the esophagus, you can actually see the lower esophageal sphincter, which is the doorway between the esophagus and the stomach. And if that drug is albuterol, you are depositing a bronchodilator, a muscle relaxing medication, onto the lower esophageal sphincter, and you are almost certain to cause gastroesophageal reflux, which has its own confusing symptoms of chest pain, chest discomfort, shortness of breath, and so forth. And then that big glow there that you see at the bottom of that path is the stomach. So most of this medication is going to end up in the mouth and in the stomach. And in the second picture, same adult individual, same radiographic technique, scintillography. You can see a dramatic reduction in the oral dose and a huge increase in pulmonary delivery. So we are big believers in the use of spacers. Next slide. And not too long ago, one of the major manufacturers put one of the most important features on their spacer that anyone's ever installed, and that's that little dome at the top. I have a red circle around, and it's present both on the standard chamber that goes in the mouth and the chambers that have masks. And what that little leaflet does is when the breath starts, the leaflet leans towards the student, and when the breath ends, it stands up again. So I can see if a student's just taking little short breaths, or if they actually keep the door open and continue to move air for a reasonable amount of time. And we're going to talk about how many seconds should I expect my student to be drawing aerosol medication into their lungs. 1, 2, 4, 5, 10. So we're going to talk about that. Next slide. So we developed this slide during the first year of COVID because we really wanted our students to have the best possible technique, because if they weren't getting their albuterol or their Flovent or their Pulmicort, Symbicort into their lungs, we were more likely to see them in your office and more likely to have to call an ambulance or send them home. So here are the 3 simple things that people don't do that dramatically reduces the delivery of medications to the lungs. Number 1, you have to intentionally exhale all your old air. I can blow out 4 to 6 times as much air as I exhale in a tidal breath, which is the normal quiet breathing that I would do sitting in your office. So completely emptying the lungs means you're going to be able to draw 4 times the volume of air, and you're also going to be able to draw that air deep into the lungs, whereas a tidal breath is pretty much in the top of the airway. And then aim up. When you think about the enemy of lung deposition, one of them is aerosol particles have to fly around curves. And if I'm looking down, if I'm aiming down, I'm asking the medicine to go up a hill, over my tongue, around a sharp curve, and back down to the lungs. But when I aim up, I'm creating a downhill path all the way to the lungs. And I like to say to kids, make a slide for the medicine to go to your lungs. It should all be downhill. And then the last thing is fill up slowly. And many of our chambers have a whistle, right? That's what that is. And if you hear it, you're going twice the recommended speed. So I say, if you hear the whistle, what does that mean? And the student should say, slow down. But many think it's a good thing, that they're doing it right. So we have to do a little education there. And I'll say, if you hear the whistle, slow down. You don't want to get a speeding ticket. And they laugh, but they remember and get the idea. Next slide. So one of the challenges in doing this really special technique is I need to know how many seconds a student should take to fill their lungs. And the best way to know that is to measure their FEV1 using a digital meter. And we've distributed hundreds of these in schools and clinics, and we are not using them during COVID-19. So that's a loss. So we're having to estimate, based on the age of the child, what their target time, how many seconds they should take to fill their lungs. So this is how we're doing it: 2 to 3 seconds for an elementary age student, 4 to 6 seconds for middle school, and 6 to 10. And you can pretty much let height guide you. If it's a 6-foot, 16-year-old that plays basketball, he's probably 8 to 10 seconds. So where do these numbers come from? They come from the difference in lung capacity. So a 5-year-old may only have 1.2 liters of air that they're able to exhale in 1 second. That's the FEV1. So we double that 1.2 and it's 2.4. So it's between 2 and 3 seconds. By middle school, these kids will have lung capacity of about 3 liters, so it can take up to 6 seconds. And my high school athletes and tall individuals are going to have lung capacities in the range of 4 to 5 liters, and you double that, so that would be 8 to 10 seconds. So the best way to do this is measure the FEV1 and double it. Next slide. But we can do it by estimate as well. And I'll end on this thought that it is so important that we work together so that the education that we do in the clinic, you reinforce and strengthen in the school. And that if someone goes to the home to check for indoor triggers, that they're using the same language, the same messaging. What's your controller medicine? What's your target time? How long do you take to fill your lungs? Are you spraying it in your mouth, naked technique? Or are you using a chamber so it actually goes to your lungs? Next slide. So the guidelines are real clear on this. We're not going to get this done with education in the clinic twice a year when the patient shows up because they need refills. So if the pharmacist and the school nurse and all of us are doing this, we are going to have much better outcomes. Next slide. So that's our focus, all points of care. And if we talk together, work together, we will develop common messages. And we're doing that through a system called ECHO, Extension for Community Health Outcomes. So we have video calls with school nurses and home assessors, environmental assessors, and clinicians and social workers and nurse care managers. And we love it because we're learning from each other what our challenges are, what our opportunities are. And I think we're just going to get better as we learn together and collaborate. Next slide. So the basics, most kids don't know. They really don't know the difference between their inhalers. They really don't know what asthma is and how long they're going to have it. They really don't know what the peak flow means. So at every opportunity, we want to begin to make this make sense, make it actionable and useful for students and their families. Next slide. We are fortunate in Missouri. We now have a website that the managed care organizations are supporting so that our school nurses can find out how to get free dust mite covers for the students that are dust mite allergic, or how to find out how to get a care manager to work with a family that's struggling financially or struggling with transportation to get back to see their healthcare provider. And I think that this is the right direction for us to be moving, is to address these social determinants of health that really get in the way of families doing what they want to do for their child. Next slide. So I think I'm going to stop here, Angie, and just take questions and comments. We did develop a program in Missouri called Teaming Up for Asthma Control, and this includes online training. We use Canvas as our learning management system, so you can do it anytime, anywhere you have high-speed internet. And we do provide equipment. We provide digital FEV1 meters and in-check dials, which help you assess whether a student's able to breathe in their medicine effectively or not. But let's stop there and take your questions and comments.
We don't really have any asthma specific questions.
Okay.
But we do have one that I had mentioned earlier, and
Okay.
I'll get your input on it as well. It was about doing NEB treatments in the school during COVID. And I had reached out to the CDC and to get their, recommendations, since, we don't have negative pressure rooms in schools, and their recommendation, of course, was that they could be performed if the nurse was wearing a N95 mask and you're
Right.
in an isolation room and, you do your deep cleaning afterwards. This school nurse is saying that, they don't have N95 masks.
Right.
And they kind of saved them for when the need was so bad for hospitals to have them, and wanted to kind of know their opinion. I personally recommend, I think every school nurse needs an N95 mask, because they're kind of the front line at the school. What's your thoughts on that?
Yeah, so we dealt with that here in the state, and both the American Academy of Pediatrics and the CDC recommended against using nebulizers, except in the most desperate of situations. And so first of all, we have used this special type of chamber that has the flow indicator where you can see if a child's breathing. And it comes with 4 different mask sizes. We made a kit available to every school district early on last summer, so they could see that there was a way to be more effective with meter dose inhaler use. So if albuterol is given and it's effective, then by meter dose inhaler, then you don't need a nebulizer. So that's our primary approach. We also enacted an emergency protocol. We wrote it up. We shared it with districts. Each district has to adopt it themselves. But our national guidelines say you can give up to 6 puffs of albuterol. And we kind of went with the theme, you can do this without nebulizers. Our emergency room here at Children's Hospital, University of Missouri Women's and Children's Hospital, they do not use nebulizers routinely. They use 6 to 8 puffs of albuterol, and then they'll repeat that in 20 minutes, and they'll add Atrovent, ipratropium, same way, 6 to 8 puffs. So I think that is a solution. We also have had unique situations come up where they used a bathroom that had a good vent fan and administered a neb treatment in that bathroom because that was the only option. But to be with that student and attend the student, you do need full PPE and an N95 to protect yourself. So there's a real risk of aerosolizing, particularly the Delta variant, and you would have to leave that room unused for hours, and that's just not practical.
Thank you. And that's a perfect answer. And if you're having trouble getting an N95 mask, reach out to your local health department. They may be able to help you. I know they can definitely help you with the fit test, to get your nurses all fit tested for the N95 masks. But our school nurses are just as important as our ER nurses and our ICU nurses. So you need to be taking full advantage of PPE use and use what it's out there. I know it's not fun to wear an N95 mask all day, but it's just the nature of the beast right now that, the school nurse sees everybody and everything, and you don't know what's going to walk into your office. So you need to be prepared at all times. So, and that's the only question we have right now, Dr. Francisco. If there's anything else you want to talk about, or.
Well, I think this is probably a good stopping point. I just want to encourage you that what you're doing does make a difference, even when it's just carrying on a conversation. What color is your inhaler? Why do you take it? And just helping kids understand what's the path to getting their asthma under control. We found in Missouri 3 sessions with a student with an asthma trained school nurse had dramatic impact on those kids. Their lung numbers went up, their psychosocial functioning improved, and our state Medicaid program saved about $1,400 in the following year. And that happened because kids didn't know why they were taking their meds. They didn't know how to get it in their lungs. They didn't know the importance of identifying and avoiding triggers. And the school nurse made that critical difference by just supporting them. And she had tools to do it. And that's the key. We do need tools. We need to be able to measure airflow A peak flow is not as accurate as an FEV1, and these new meters are going to get you both. So this is going to be terribly important after COVID's over and we can kind of go back to our normal life. All you need here is a personal mouthpiece for that student for a year, and they cost about 50 cents. And now you have a lung number that has meaning to you as you teach how to breathe in the medicine, but it also has meaning clinically to that healthcare provider who may not understand just how sick the kid is.
Also, do you mind sharing again the brand names of those spacers that have the
So this is the Aero chamber, AERO chamber, and it's called Flow View. So there are different models of this. Let's see, like here's the old one. The old one had the whistle, but there's nothing on top. And here's the new one, still has the whistle, but now you can see when the breath starts and when it ends. And parents love this because they didn't really know how to coach their kids either. So this is perfect for the school and perfect for home. And we've actually worked with the company Monahan, and they have developed a program to sell directly to our schools who are taking part in asthma training, and they can buy these at a hospital discount cost, which is really helpful. So less than $8. So that's helped us get chambers to kids who really need it. Our state Medicaid program approves and pays for this. It's available through our Walmarts and many other pharmacies. I will tell you real quickly that this is another useful device. It's called a train hailer. And unlike our placebo MDI, there's no drug and it doesn't expire, and you can do a surface wipe down between student use. And what this enables us to do is hand to a student their chamber and a practice inhaler, so you can watch to see, do they squeeze before they start their breath, or are they breathing before they squeeze, which is the biggest mistake that we see. Are they aiming up so the medicine is traveling downhill all the way to the lungs? And are they keeping this indicator open for the expected amount of time, depending on the age of the student? So I think these are really important tools that we're working. It's not an easy fix. We have over 500 school districts in the state of Missouri, and we're doing everything in our power to get this equipment to them and to get their healthcare providers to send an asthma action plan to school, to put on that plan what is their best FEV1, what is the target time, to really give you enough information to be able to really support the student. So every visit, a student receives a chamber. The first one is for home, the second one is for school in our clinical setting. And we're encouraging clinicians to do that.
Awesome. Dr. White, do you have a question for Dr. Francisco?
Yes, sorry. I was trying to sneak it in the chat. All of that was so fascinating to me. Being an OBGYN physician, asthma is not the first thing on my mind. So
Sure.
very helpful. But what did perk my little bureaucratic ears was the part
Right.
when you said about the money saved by Medicaid.
Right.
I'm always looking for, we know that school nurses save millions of dollars.
Right.
But when somebody actually puts it together in a report or a paper, that's always helpful for us at Public Health to be able to share that
Sure.
with our sister agency. Is that published? Is that a report that y'all have there in Missouri?
It is published, and it was published in Preventing Chronic Disease.
Okay.
If you'll Google Teaming Up for Asthma Control, CDC, you'll get a direct link to the article.
Perfect.
So we have a very positive relationship with our state Medicaid program, and for more than 10 years, we have been analyzing their administrative claims to understand what's happening to children with asthma, and we are using that to help clinical practices be more effective. So we've developed a sort of a grade card for them called the Asthma Risk Panel Report, and they can see what percentage of visits for their patients are occurring in the ER and hospital.
Great.
And on average, 30% of all asthma visits across the state, both urban, inner city, and rural, is somewhere around 30% of care is still happening in the ER and hospital. We have a standardized program for those clinicians to adopt best practices, and it received a national award last year from the American Board of Medical Specialties. And it won that award because we used claims data to help people know where they were starting and if they were making progress. And on average, our participant clinicians reduced the acute care visits by half.
Wow.
So their score went from a 70 to an 85, or we say from a D to a B plus, right? And they like that.
Yeah.
And they want to know they're at-risk kids. They can see who hasn't picked up an inhaled steroid in 6 months from this report. They can see who's used 10 albuterol inhalers, which is a real worrisome thing. So it's been a great partnership, and the key is we're interested in what's actionable. If we can see it in claims data and make a difference, then that's what we're going to do.
We'll get our chronic disease folks that we have an asthma program there. So we'll get them our people will talk to your people, because this is very
That sounds
exciting.
great. That
Thank you
sounds
so
wonderful.
much.
Very good to meet you, Connie.
Yeah.
Okay, I don't see any other questions submitted. Guys, if you think of something later on, feel free to email me and I will direct it to Dr. Francisco and make sure that you get your question answered. It's been a wealth of information, and I thank him very, very much for taking the time to be with us today. Keep up the good work there. Keep up the good work there in Missouri.
All right, and I'm a Tennessean by birth, so my heart is in that region. So I wish you all the best.
Thank you so very much.
You're welcome. Bye-bye.
Bye-bye.